Well, good morning, everybody. Thank you so much for coming, those of you in the room, and thank you for tuning in. I understand, a couple of hundred of you who are watching this online. I'm Paul Johnson, Director of the Institute for Fiscal Studies, and I'm really pleased to be hosting this event, What Next for NHS Waiting Lists. We've published a new piece this morning, the third in a series of pieces that my colleagues Max Warner and Ben Zaranko have put together over the last small number of months, really trying to dig into the public data on what is happening with the NHS, its resources, the waiting lists, and what might happen going forward. And they've done a fantastic job on that, and Max in a moment will take you through some of the outcomes of that. Now, as you know, this is the first year, I think to the day, of the NHS's elective recovery plan, designed to get a handle on those waiting lists, and I'm just absolutely delighted that we've got three very expert speakers to follow on from Max, who I hope will speak for about 5 minutes each, and then we'll move on to a panel discussion. The first, of course, is Sir Jim Mackey, known, I'm sure, to everyone here, the Chief Executive of Northumbria Healthcare NHS Foundation and the National Director of Elective Recovery. Sounds to me like two more than full-time jobs, so how hell Jim does that, I don't know, but anyway, he does. Even more delighted, therefore, he's found the time to come and speak here this morning. Then we've got Victoria MacDonald, who is the Health and Social Care Editor at Channel 4 News, so I'm sure will be known to most of you for her reporting on health particularly, and the in-depth studies that she's done on that. And then, as it were, right from the front line, we have Dr. Roberto Tamsanguan, if I've got that slightly right, who is actually a practicing GP in East London, and among many other things is a member of the government's Elective Recovery Task Force. So we've got a whole range of inputs into this conversation today. I hope it does become a conversation. As I say, Max will do a presentation, then we'll have 5 minutes of introductory remarks from the other panellists, then I will chair a short panel discussion, but plenty of time for you in the room to put up your hands to ask questions, and people online to ask questions on Slido. And as ever, do bid up or vote up the questions you like, because they're the ones I'll see first and the most likely ones to get asks. So with no more ado, I will hand over to Max.
Okay, thank you, Paul, and thank you everyone for being here. So I'm going to start by setting out some new analysis of waiting lists that we published today, really building on work we've done at IFS over the last year or two on waiting lists. So, big picture, this chart here shows the number of incomplete pathways for NHS treatment in England since comparable data. I'm sure many of you have seen a version of this chart, and I think there's three big things to take away to set the scene here. First, waiting lists were already rising pretty steadily before the pandemic, for a number of years before the pandemic. Two, at the dashed line when the pandemic starts, waiting lists start rising much faster, reaching 7.2 million in November of last year. And third, not only are waiting lists rising, perhaps unsurprisingly, the length of time people are waiting is also rising. So in green we have the number of people waiting less than 18 weeks. That's the NHS constitutional standard. And you can see the increase in list size is really coming from those waiting more than 18 weeks. In red we have those waiting between 18 weeks and a year, and in yellow those waiting more than a year, where there's almost no one pre-pandemic. There's now several hundred thousand. So with this kind of background, a year ago to the day, NHS England published its elective recovery plan. And that really had two key parts that we're going to focus on today. The first was reducing long waits, and in particular, waits of more than a year. And the second was increasing elective activity to about 30% above pre-pandemic levels. Now, there were other areas, so there were targets for diagnostic tests, cancer referrals, and outpatients. I'm not going to focus on those today, but Sir Jim might have some things to say, and we can always touch on them in the Q&A. And then just to highlight the political importance of this, just a few weeks ago, Rishi Sunak, the Prime Minister, let NHS, or reducing NHS waiting lists, be one of his 5 key priorities for this coming year. So, as a bit of a roadmap, I'm in the first half going to look at how the NHS has performed against its plan, and in particular these two key pillars of long waits and treatment volumes, and then we're going to look at what this might mean for waiting lists going forward. So starting with long waits, this chart here is going to show the number of people waiting different lengths of time for NHS treatment, and the dashed line in the middle is when the plan was published in February. First, at the bottom, we have this purple line, the number of people waiting more than 2 years for treatment. Now, in the plan, the target was to eliminate these waits by the summer of last year, and as you can see, that's broadly been successful. Between when the plan was published and the latest data in November, the number of people waiting more than 2 years has decreased by about 94%, and there are now about 1,000 people waiting more than 2 years. In blue, we have those waiting between 1.5 years and 2 years for treatment. The target hasn't yet arrived for this. The target is to eliminate these waits by April of this year, so there's still a few more months. But as you can see, since the plan was published, that's pretty much flatlined. And then in yellow, we have those waiting between 1 year and 1.5 years. Here there are two sets of targets. By March 24, to eliminate waits between 1.25 years and 1.5 years, and by March 25, to eliminate those between 1 year and 1.25 years. And as you can see, those targets are far away, but over this period, that number has really increased quite dramatically. So, in our view, the NHS has been very successful and almost completely eliminated waits of more than 2 years. That's the only actual hard deadline in the plan that's passed, and we think they've been successful there. There are still some, about 1,000 remaining, but it was unlikely they were ever going to eliminate that entirely. When we look at total long waits, though, defined as those waiting more than a year, actually the total number has risen since the plan was published, with more coming down the track as people continue to wait and cross over that year threshold. Now, those targets are not yet, their deadlines aren't there, there's still time to achieve them, but the crucial thing is that means the next targets are going to involve a lot larger number of patients. So at its peak, there are about 24,000 people waiting more than 2 years for treatment. Currently, there's about double that waiting between 1.5 years and 2, and an order of magnitude waiting between 1 year and 1.5 years. So in our view, these subsequent targets are very challenging. They're probably going to be harder in terms of total number of people than a 2+ year, but we think they remain achievable within the time frame of the plan. Moving on to kind of increasing total elective activity, this chart here shows the number of patients treated from the waiting list since 2008, and what we've done in the black line is project forward the pre-pandemic trend had it continued. And you can see the really sharp decline at the beginning of the pandemic. And you can see, although total treatment has returned a lot, it's still far below the pre-pandemic trend. And actually, we can go a little bit further than that. This chart here in green shows the total number of people being treated from the waiting list in each month that we have of 2022. And then in the dashed line, I've put the 2019 number treated. And you can see, big picture, in 2022, the NHS actually treated fewer patients from the waiting list than it did in 2019. Now, you can see there's a bit of an encouraging increase towards the end, and there's actually about 5% above in November. But if we look at the year as a whole, NHS was treating fewer patients from the waiting list. Now, this was true both in yellow, we have admitted care, so these are people going into hospital from the waiting list, and for non-admitted, so this is really outpatient. We see the same kind of pattern across both types of care. And this is also just a really good reminder that actually the majority of the waiting list we often think of as surgery, but the majority is actually outpatient, non-admitted care. Now, this isn't just something that's special about elective activity. This happens to pretty much any measure of hospital activity you look at last year. So this chart here shows the number of patients being treated by the NHS in the first 10 to 11 months of 2022 compared with the same months in 2019. And you can see treatments from the waiting list are about 8% down over the first, I think here, 10 months. But this is true for lots of other care too. So you see that for emergency admissions, ambulance incidents, A&E arrivals. There are a few places that are doing well in terms of volumes, like primary care, but big picture, in 2022, the NHS was treating fewer patients than pre-pandemic, including, but not only, elective activity. So, in our view, there's been very little progress actually increasing elective treatment volumes so far. And of course, that's likely due in part to broader pressures that are affecting the NHS. We've written extensively in our previous report about those pressures, and that's something we can discuss in the Q&A if people want to. I think it's also fair to say to the NHS that actually maybe a lot of this growth in treatment volumes was always planned to be backloaded. After all, it does take time to increase treatment capacity. But I think even if you account for that kind of backloading of growth, I think we're still not where we'd want to be in terms of total number of patients being treated. Okay, so given what's happened against the plan so far, I think it's a pretty mixed picture. Success against long waiters, still struggling to increase volumes. We can then see what this might mean for waiting lists going forward. And earlier I said the NHS's target was to increase elective activity by 30% relative to pre-pandemic levels, but it's actually a little bit more complicated than that. In particular, that 30% number includes a greater proportion of activity taking place outside of hospitals, so patients not actually ever getting on the list, getting treated in another way. And in particular, advice and guidance services that maybe Roberto might talk about in the Q&A or later, allow GPs to talk to hospital doctors to discuss a patient before that patient is referred. And the goal of this service, very explicitly, is to reduce referrals onto the waiting list. So if we take the plan and break it down a little bit, by 24-25, the plan is relative to 2019-20 to increase actual number of patients being treated by hospitals by about 21%, then have an additional 8% pathways avoided via advice and guidance, so patients not actually joining the list, getting care in another way, adding up to that operational target of a 29% increase in total elective activity. And that's where the 30% target comes from. Now, in our view, this is a very challenging target. We said a year ago when the plan was published, this was a very challenging target, and not much has happened since then in terms of total treatment, which means it just remains an even more challenging target. In particular, we're not starting from 2019-20 levels. If anything, we're starting slightly below. So in September to November, the last 3 months of data we have, on average, the NHS was treating about 3% fewer patients from the waiting list than pre-pandemic. So we can now think what this might mean for what's going to happen over the next couple of years. And so I'm going to repeat that chart we saw before with the total number of patients being treated from the waiting list. And then I project forward a little bit further that pre-pandemic trend. And then we can think what might have to happen if we want to achieve that target. And in particular, the yellow line shows what would have to happen to treatment volumes if we were going to hit that 21% in 24-25. And as you can see, that requires really quite rapid growth, going well above the pre-pandemic trend. And in particular, that's much faster growth than we see at any point pre-pandemic, would require about 10.3% annual growth in treatment volumes over the next 2.5 years, which is an incredibly high number. It's certainly possible that that can be achieved. In our judgment, we think that's simply unlikely to be achieved. It's just such a high increase over the next 2.5 years, even in normal times, and the NHS clearly isn't in normal times. So when we think about what could happen next to waiting list, we make two different assumptions as well. In blue is our medium growth assumption. This we assume the NHS gets back to that pre-pandemic trend, and that requires a still very impressive 6% or 5.9% increase in treatment volumes per year over the next couple of years. We also make a slightly more pessimistic assumption that the NHS only gets sluggish growth, and that's about 2.9% a year, roughly what they were doing the 5 years before the pandemic. So we can then take those different assumptions and think what they might mean for waiting lists. But crucially, the other big unknown is for waiting lists is the number of patients actually joining the list. Now, a few months ago, or half a year ago now, you can calculate that there are between 7 and 8 million patients who would have joined the waiting list had the pandemic occurred, who didn't. And these are often called missing patients. And fear that these millions of patients, or a big proportion of them, would return, led to previously, including our own, very high projections for waiting lists. For example, Sajid Javid warning 13 million. We could easily generate numbers bigger than 10 million if you assume a lot of these patients came back, as we thought, I think everyone thought at the time, was quite likely. However, there's so far no evidence of a surge in demand. If anything, the number of patients joining the waiting list is still a couple of % down on pre-pandemic levels. And I think this is a really important point. That is amazing for waiting lists. That is really the only reason waiting lists haven't surged last year, when treatment volumes were a little bit below pre-pandemic levels over the year. That doesn't necessarily mean it's good for health. If these patients are getting care elsewhere, then that's great. If they're not, then clearly there's concerns there, even if it's good for the total waiting list. So for our modelling, we assume 3 different scenarios for the number of patients joining the list. In a high scenario, we assume some level of catch-up demand, but still much lower than we've assumed in the past, given what we've seen. And in the low case, we assume really stable demand, with the number of patients joining the list only really returning to pre-pandemic levels. And again, that's quite remarkable, returning to pre-pandemic levels despite having a larger, older, and sicker population. Okay, so we can then take these different assumptions and think what they might mean for waiting lists going forward. So the green line here shows what has happened so far to waiting lists. And again, we can then project forward what might happen under different assumptions. I'm going to start in yellow, which is our central scenario. This is the thing we judge most likely to occur, but there's a huge amount of uncertainty here. We think it's unlikely the NHS is going to achieve this mammoth 21% increase in treatment volumes by the end of 24-25. We instead think in our central scenario they're more likely to hit a medium growth, which is still historically very impressive, and correspondingly there'll be medium growth in demand, or the number of patients joining. And here you can see what that really means is waiting lists more or less flatline this year before starting to fall gradually middle of next year. Now, what happens if the NHS does achieve that plan? Well, in green, or in blue, sorry, we show what would happen if the NHS did achieve its target, it did ramp up volumes, but correspondingly there was some level of catch-up demand. Suddenly more patients did start joining the list. You can see waiting lists do start to fall this year, but they fall relatively gradually. Now in orange, or red, I show what would happen if again they did achieve their target, but instead of a surge in demand of patients for care, we actually see really limited, stable, we might say rationed demand, and actually it only really returns to pre-pandemic levels. In that case, you can see waiting lists start to fall much faster. And this really just emphasises, in both the blue and red, NHS has done the exact same thing with treatment volumes. All we're changing is how many patients are making it onto the list, and you can see we get really quite big differences in outcomes. Now, both of those are relatively optimistic. So in purple, we show a bit more pessimistic scenario. That's one where the NHS is only able to achieve sluggish growth in treatment volumes, and there's some medium growth in demand. And there you can see what happens to waiting lists is they really just continue growing over this period at a slower rate, but they don't start falling before March 2025. So there's clearly a lot of uncertainty here, and we really want to emphasise this isn't necessarily a prediction, this is just showing what could happen under different sets of assumptions. Our central scenario, though, the one we, in our view, judge most likely, is this kind of medium scenario of medium growth in treatment volumes and medium demand, leading really to a flatlining this year before falling next year. So to conclude, in our view, the NHS has done really well eliminating waits of over 2 years. That's the only target that's actually passed, and they've essentially achieved that. Subsequent ambitions for long waits remain really quite challenging, but we think they're broadly achievable. Where we see less success is increasing total elective treatment volumes. And crucially, while volumes are low, you can only prioritise certain parts of the list, you can't reduce the total size of the list. Therefore, in our central judgment, we think it's going to be very hard for the NHS to achieve the plan on time to increase elective activity. And so in our judgment, waiting lists are likely to more or less flatline over the next year before starting to fall steadily from the middle of next year. However, again, I really want to emphasise there's a lot of uncertainty here. This depends both on what the NHS does, what patients do, what GPs do. All of this feeds in, and it's certainly possible that waiting lists could fall this year, as the Prime Minister wants. I think there are really two cases that happens. One, the NHS increases treatment volumes even faster and kind of on track with its plan, which would be very impressive. Or the number of patients joining the list stays where it is now, unexpectedly low. Again, despite having an older, larger, sicker population. And that might be because patients don't need care or they're not coming forward, or because they're unable to access that care. Okay, that is everything from me. Thank you very much. I'm going to hand over to Sir James for an NHS perspective on all of this.
So that was great, and I think it's a great bit of work, and we would broadly support the analysis and the findings as well. But one of the things I've learned in the last 18 months is you can do loads of modelling, but reality beats you every time. And this is really complicated. So I'm just going to talk you through how we got the plan together, the things we're focused on, how that's worked, and I'll give you a bit of a hint in terms of where we are actually now. When we first got involved, so I got involved in this in October, whenever that was, 21. And you looked at the backlog effectively around the country, it was very variable. So it was hugely different in different parts of the country. Some organisations much more affected than others, some specialties more affected than others, etc. So we had to come up with a bit of a national plan, but recognise huge variation in impact, partly of pre-COVID performance, but also the impact of COVID and extended lockdowns. It was very hard to work out where to start as well. We thought the fairest thing to do for patients was focus on long waits first of all, and to help the NHS and everybody get their head around what we needed to do, bite it off into manageable chunks, and that's described in the plan, making a start with the very longest waits, 2-year waiters, and then just sort of gradually work through and eat through the plan. As has been highlighted, through a very, very messy winter last winter, 21 into 22 with Omicron, etc., the NHS actually managed to get there broadly on 2-year waits, and then it's continued to be complicated through that period with extensions of periods of COVID occupancy, a lot of COVID in the community. Then what happened in winter, COVID, flu, strep, you name it, industrial action. So we're in a very, very complicated operating environment, but the NHS is gradually getting there and gradually picking up pace. We've had to work out through all of that how we support organisations recognising that variation. So very early on it was very clear that the Northwest and the Midlands were very badly affected. Latterly, Southwest became very affected last Easter with a rise in COVID, etc. So created a bit of a tiering approach so that we had focus on those that were going to get there themselves and didn't need much support versus those that were going to need a lot of help from others around the NHS and us in the central team, etc. This time last year, there were roughly 73,500 people who could have waited 2 years, and then we managed to get that down to about 1,000. It's about 1,000 as we stand here today. On 18-month waits this time last year, we were looking at an enormous number of patients who could breach 18 months at the end of this March. So about 1.7 million, I think the aggregate number was at that point. As of today, we're about 104,000, and that number is falling between 15 and 20,000 per week. So the actual number of patients who've reached 18 months has been static at about 50,000 for a couple of months, but the cohort is reducing very, very dramatically as we move towards the year end. We've done an awful lot of work led by Paul and other colleagues across the NHS in the last few weeks to understand where people actually are, and a really big focus on getting patients booked in and massive progress on getting people booked in, which gives us all more certainty in terms of where we're going to be. So it's not going to be easy, but the NHS is still moving the right way with huge volumes now, so much bigger volumes than we were on the 2-year wait. And also through a very, very messy winter period, so everybody knows it's very hard over the December, early January period, the NHS still managed to make progress electively during that time, which is absolutely fantastic. From a cancer point of view, has already been pointed out, the big first priority was to make sure people felt able to and did come forward and were referred when they had cancer symptoms. The programme's really successful at that. That then gives us a separate problem of then having to treat them, and the services working through that, and the gap between where we were last year and this year has been closing very dramatically week by week, with great progress now starting to work through on the cancer programme. So not just having found the patients and get them into the system, the NHS then sorting treatment out for those people as well. Again, as has been pointed out, the plan prioritises a few things, and one of them is a big separation of urgent elective care, which doesn't get a lot of public sort of acknowledgement, but it's a big step for the NHS to formally acknowledge we need to try and separate the streams and build resilience into both, supported by a really big expansion. A lot of the expansion kicks in the coming year. So again, on your points in terms of when activity picks off, we'll still have workforce challenges, but a lot of the physical capacity in surgical hubs and diagnostic expansion happens in the coming year. And also been working very actively with clinical colleagues on making sure prioritisation is appropriate in organisations, especially that are struggling, and also, a massive amount of innovation around the NHS, not just the hubs, but the use of robots, the use of AI, the use of different techniques, the approach to fit testing, for example, in cancer. And I think on advice and guidance, there's a lot of development now on how advice and guidance works. It's a much more fluid and informal thing, as often described. My view is we're probably still not capturing all of that informal activity, which is allowing people to be sorted out without being pushed into a formal referral system. And one of the things we're still very, very keen to do is to enable patients to have more control of their pathway. Understand where you are, organise tests, communicate with clinical teams, take ownership of your own care where you can and you want to. And that will be kicking in over this next few months. So one of the things early on that really hit us hard was the NHS was obviously very tired after the first sort of year or so of COVID, telling the NHS they needed to do a huge amount of work to get on top of this. Obviously a bit of a difficult message, and a really strong view that we need to be smarter as well in what we're trying to do. Let's not just try and do everything that we used to do, find new ways of looking after people. So special advice and guidance is part of that. The PIFU thing is a really big part of that. So again, on the waiting list, there are about just around 7 million people on the waiting list. Only 3% will have an inpatient surgical stay. It's still the case that it's constantly reinforced to people that the waiting list is people waiting for surgery. It is absolutely not. About 5 million of that waiting list, 5.5 million, will end their episode in outpatients. Outpatients is where the vast majority of the experience is for patients. So we really got to find ways of changing how outpatients work. 2 million outpatients a week, and roughly 60 to 70% of that is review volume. So we've got to really eat into that in this coming year, and giving patients control is a really big thing, as was said before. And the hubs and high volume, low complexity thing was already in train pre-COVID, and is really starting to accelerate there now. And a lot of technology in play now in the service as well, from validation tools, triage tools, robots to support surgery, you name it. There's a massive amount of technology in play in the NHS. Tomorrow I'm talking to a group of theatre staff in the North West, where again there's a momentum for everybody to look at models of care to make sure we're all as productive as we can be. The NHS actually has more people than it had pre-COVID. We've now got to really try and deploy them to what we need to do, and being really creative about acknowledging productivity, having the data, considering new models of care, and where people can really adjust what they do to really stay on top of what we've got to do long term is obviously a big thing. There are signs as well. So we went through all of the models that we've just walked through there in the earlier presentation, and the missing patients thing was the real big issue in all the original modelling. When we produced the plan, there were roughly 10 million missing patients in theory, and if they all appeared into the NHS, we would have absolutely collapsed. There was no way the NHS could have coped with that. And I think the NHS has seen those people in urgent care and in cancer care, advice and guidance in lots of different ways. So it is starting to look like a lot of it's fed through. We've got some work going on currently, just about to conclude on how we might better understand that. But that was a really, really big thing that led us to quite a large waiting list prediction, the size of the list getting over 9 million before it started to fall. The signs in the last 3 months that the list could be stabilising. So for the last 3 months, including the published stats that will come out tomorrow, will show that the NHS the waiting list has barely changed over 3 months, which is a fantastic thing. So none of that complies with any of the modelling we've done so far. It's just the reality of what's happened. So it is possible that we can get into play to reduce the waiting list maybe over this year if those things work. There is always a bit of a seasonal thing over the Christmas and New Year period, but it does look fairly strong in the data. And we've learned a lot over this last sort of 12, 15, 18 months as well, and the NHS has learned a lot. So I'm just going to skip through a couple of examples, not in great detail because I could give you 20, 30 of these things, but the way the NHS and trusts and systems have really tried to understand what their issues are and find new ways of dealing with them, sometimes with our support, sometimes by themselves, or support from other trusts has been really powerful. North Bristol, they're really getting a hold of their cancer performance last year. And Hull, who always have lots of challenges, is a very complicated place, Hull, lots of urgent care challenges, problems in social care, etc. Had huge backlog problems right at the beginning of this programme, and have made fantastic, really fantastic progress with support as well. A lot of the things done in those two organisations are attention to detail and the basics and the fundamentals. So there is always a temptation in this to find a silver bullet, some clever new thing that sorts it all out. There's an awful lot of just basic processes, fundamental processes that are required that will allow progress. And some of that was covered by the King's Fund work before Christmas as well. But it is starting to bear fruit there. And in terms of things we still need to understand, so every few months there's something else pops up, there's something for us to get our heads around. I still really think we need to be very, very focused on outpatients and find ways of freeing up capacity for the people who really need it most in an outpatient setting. And some examples where people are really starting to power on with that. Surgical transformation is very important as well, as is diagnostics. Diagnostics is especially important because it is the thing that facilitates most care in a hospital context, being pulled between urgent care, elective care, cancer, etc. And you can see that in play now. And cancer, again, just really driving through innovations in cancer. I mentioned FIT earlier, but there's dozens of them in cancer services as well to make sure we get on top of this going into this next period. I think understanding the workforce and how we deploy people to best effect is obviously a really big thing for us as well as we move into this next phase. Reflecting back, a lot of this has been done in a rush. It's been built in flight. We could really do with stronger patient engagement on this, and Stella Viggs and other colleagues are really trying to work on that as well currently just now. Really understanding what is in the list, what does the list mean, because it's not a list of people waiting for surgery, and those people who are on multiple pathways is still a big thing for us to understand, and we're just starting to get our heads around that with huge potential in that as well. Really trying to get more local ownership as ICBs. Take flight as well, because in the beginning ICBs didn't legally exist, so we had to build an operating model that worked with the NHS, allowing them to get established, etc. Really big need for clinical drive, and Tim Briggs through the GIRF team, Stella Viggs, Ian Eardley and other colleagues are really working hard on this with us. So a lot of the interactions with trusts in the last few weeks have been very clinically led as well, rather than managerially led in the beginning. And I think just accepting that there is no easy way out of this. Some of it's innovation, some of it's new technology, some of it's just hard work, waiting list validation, PTL management, all those things. And be really good as well for this to feel like it's a big national endeavour that we all need to pull together on to get patients what they need. So overall, I accept that it's a bit of a mixed picture. Success on the 2-year wait. We're still confident of delivering the 18-month wait. Some signs of stabilising the waiting list, but still an awful long way to go.
Thank you. Wonderful. Can I now turn to Victoria first to give your perspective on some of what you've heard?
Well, it's positive mostly, isn't it, that at least something's been done. And I was just thinking, well, two things. One, that I missed December because I went to New Zealand and it was really lovely and sunny. And I tried not to look at my emails. But of course, what was happening here was, to a lesser degree, because it's smaller, was happening there. So my own mother is now remortgaged at the age of 82 to have a hip replacement. It's exactly the same scenario. Problems with shortages of staff, backlogs from COVID, not enough capacity. all the things that you've gone through. And we know that it's happening in different countries in different ways, but with the same outcome. When I'm reporting, so came back right smack bang into the middle of us, of course, in the first week of January, and the two things that stand out there are that when I was going into hospitals to look at emergency care, particularly, not one hospital hadn't got some fantastic scheme for dealing with not only the problems at the front door, but the problems at the back door, the problems with the build-up of elective care. Secondly, none of the patients complained. I spoke to one woman who had been on a trolley for more than 20 hours by the time I saw her, in incredible pain. And I hadn't asked her the question. I'd actually just said, how are you? And she said, it's the NHS, and I'm glad we've got it. And I said, well, that wasn't actually what I wanted you to say. And that won't fit into my script, but great. And then I went to Warwick Hospital the next month, and the same thing happened. Before I could even open my mouth, they wanted to say, we love the NHS. And yet, we can see from some of the polling that the NHS has now taken over in the concern of the public are feeling most concerned about above the economy. And I've been covering health now for 35 years in this country, in other countries slightly longer. And I can't remember that ever happening. It certainly moved up in the polling. It always used to be around third place, then it moved up to second. I've never known it go into the first place. Now, it might have been a blip, it might have been just that it was a bad December, but I think that the government should be particularly worried about that polling, because if you're going to lose that public support. Now, I've been out on the picket lines this week, and again, you are seeing the support for the striking staff remaining really high, which I think is of particular importance, and has slightly surprised me. I thought it might have started to have waned by now, but it hasn't. And this is against the backdrop of people knowing that they are going to have to wait for their hip replacement, for their knee surgery, for cancer referral. So all of the schemes that we've heard about, and I recognise what you're saying, Jim, about the, doing some, not turning everything on its head. It feels to me that there does need to be better messaging to the public and to the staff about how you are going to reach even some of these targets, or that you are reaching some of these targets. I recognise it's my job to tell them some of that. But there is an entrenched view, I feel now, that the public and many of the staff I talk to don't believe that it's going to happen. And some of that is not your problem. Some of it is the political problem of telling us there are going to be 40 new hospitals. Thank you, Andy Cowper, for reminding me of that. And we know what the problem with that messaging is. When we're told there are going to be more ambulances and there are going to be more beds, and then when you inspect those numbers, you see that some of those ambulances are actually going to replace old ambulances, so it's not that total number of extra ambulances, or that some of those beds, 4,000 of the 5,000, were going to be temporary beds made permanent. So just one last thing is about, which hasn't come up here, particularly it's been mentioned, but unremittingly, wherever I go, and when I talk to GPs, whether I'm in hospitals, in the community, talking to social care workers, they are depressed beyond belief. They are exhausted, and there are too few of them. It doesn't matter which sector we're talking about. And I've said it a couple of times on television, but and it comes from the Health Foundation, so I don't claim it as my own, but talking about this being a poly-crisis. So we are here talking about elective care, but what we know is that this is an unprecedented crisis. across all sectors. So when I was at the Sunday Telegraph more than 25 years ago now, I remember, of course, doing stories on the crumbling facade of the NHS about long waiting lists, whatever. But other things were working. The GP service, for instance, was working really, really well. Now we've got problems right across. So we can talk about elective care, but the first discussion needs to be about getting them back out off the picket lines, and doing something about how they're feeling, about incentivizing them to help get these lists down, because I don't think it will happen unless that's the first target. You say, do something about the staff.
Thank you. Roberto.
Thank you. Really, really interesting conversations this morning. I think it wouldn't be fair but to start with the huge pressure that's on the health service, as you said, Victoria, particularly in general practice. But it was really lightening to see that the activity has increased in general practice by 4%. I think on balance, the plan really allows us to really think about how we're going to do things differently, and something that you had on your slide, Jim, work smarter, not harder. We have an opportunity to redefine the interface between primary and secondary care, and things like advice and guidance, which allows a GP to have a two-way conversation with a consultant prior to a referral, just to check that there's no other alternative option for this patient, and actually referring is the right decision. That can either be through advice and guidance or through enhanced triage of a referral. Really allows us to support a person as an individual and have a personalised conversation with the patient about, is it right to be joining a waiting list for you and in your scenario. And I think there's a huge bit that we need to do about how we support people whilst they're waiting, the waiting well piece. And I think ICSs and systems are in the best place to do that, with support from the national team, in terms of how we truly support our residents and citizens in terms of thinking about community and voluntary sector, and how we get people to be as fit as possible so that when they are at the top of the list, they're ready for surgery or treatment. But fundamentally, I think there's something about supporting GPs and the morale for GPs to be able to practice at the top of their licence, and that could be through support from consultants and other colleagues. But that will help with morale, I believe, and personalising care, because there's nothing more than a GP wants to do than to send a patient to hospital when they don't need to be there.
Brilliant. Thank you so much. I've got lots of questions here on Slido, and questions to ask the panel. I will come to people in the room in a few minutes' time, but this conversation has just brought up so much in terms of understanding the waiting lists, in terms of understanding people's experience, and what's happened in terms of people not coming back, the workforce, and so on and so on. Roberto, I want to come to you first, just with a question you may or may not be able to answer, which is, in your experience, what has happened to the 7 million people who haven't joined the waiting list? I mean, do you get any insight into that from the work that you're doing?
I think that's a really challenging question, because they're literally not in front of me. I think some patients that I speak to are quite scared about coming forward, about joining a long list and what that could mean. But I think the message has to go out, as you say, Victoria, that the NHS is there, and we're here to listen and to help and to get you to the right place and see the right person at the right time. That seems fundamental to me. But as to where the missing people are, I think it's quite a difficult question to answer, because they're not here.
By definition, and it's as Max and Jim says, it's a real worry, because if they're, I mean, we know that the health of the population, all sorts of other statistics, is getting worse over this period, and maybe that's part of the story. Jim, Victoria talked a lot about the workforce and how important they are, and that's clearly absolutely true. There's a question here on Slido about the need to increase numbers, and is there a workforce crisis in terms of numbers, or is it that there's a workforce crisis in terms of how they're managed and how productive they are? Because we know actually there are 9% more at all grades in hospitals now than there were pre-pandemic, and yet the output appears to be lower. I mean, what's your reflection on how to, what we need to do in terms of size and management of the workforce?
Yeah, so I think that's a really tricky one. I was thinking when Victoria was talking there about the mood of staff and whose job is it to sort that out. And I think, if we're honest, the whole of society is struggling with what's happened in the last few years. Our NHS staff are part of society, so whichever sector you look at, whether you're travelling or you're trying to buy something. We're all having disruption in different ways and have been affected by the last few years. So I think acknowledging that's an important thing and starting to talk about it and finding mechanisms to where those things and help people move on is important. I don't think that the 9% thing is real. So the NHS have got more people. It absolutely doesn't feel like that. So most of the conversations I have with people, and I've had this in my own organisation, we're working through it now, when you say that you've got 9 or 10% more people, almost nobody believes it. So you've got to go through a process of trying to work out, so where are they? And some of them were employed for specific things related to COVID, and we're now trying to get them into different activities, etc. But that's a difficult process, and that'll take a bit of time. And then we're still left with gaps in key areas as well. So because it's a very complex system, you can have a big gap in one part of the system that actually makes the thing grind to a halt. So it's very complicated, but the point I was going to come to is it makes me think as a chief exec, so whose job is that to sort that out? We need to solve it together, but as a trust chief exec, not in my national role, I feel like that's my responsibility to help lead my people through complicated periods. One of it is we do an awful lot of sampling of staff to understand what is on their mind, and then just going about, so you said it's problem A, let's try and fix it, and then on the comms front, talk about it and communicate it. And I think we all need to take that burden. It feels often that it's pushed at a central door, or it's pushed at in a certain position where somebody's just going to find a clever solution. It's going to take time, and we all need to work on it, because we're all, frankly, if you're not affected by what's happened in the last few years, there's probably something wrong with you. We have to acknowledge it's had an impact on everybody, but we have to get our people looking forward and focused on the future. I think that's largely a local leadership role.
Yeah, and I mean, it's fair to say, whilst there's clearly been an effect, a big effect of the pandemic. If you look back at the NHS plan from pre-pandemic, it acknowledged big problems with management of the workforce, with morale, with discrimination, all sorts of other things. So this is, I sense, an issue that's been there for a long time, the management of staff in the
Well, one of the things that I've noticed, actually, and it has come out of the pandemic, is greater focus within trusts on looking after well-being. So one of the things right from the beginning of the pandemic, going into intensive care units, you'd come off we'd stop filming and we'd go into a room where the staff could go and decompress and then go and have some counselling. They were there, and that seems to have been retained. So I asked a nurse on the picket line, whichever day it was, Monday, whether she had any help before she left the NHS, because she had left the NHS, and she said yes, that they had actually tried to help her through, but she just couldn't take the stress of working on a paediatric emergency department and the constant turnover. And the thing on the staffing was that there were staff, but they were less experienced than they used to be, which added to so although it was fully staffed, they often had to step in because they didn't have enough of the more senior staff.
What's your experience of this, Roberta? In terms, obviously you see it from the GP perspective. But do you see in the wider sector this real problem with staff burnout and stress?
Yes, we see it quite a lot in general practice. NHS England have a lot of schemes to support GPs, both with mental health and physical health, in terms of well-being. And I think it's really fundamental that we keep the workforce strong and active and able to do some of this really hard work that's in front of us.
Jim, you mentioned that this is a complicated system, that a lack of staff at one point can create problems all the way through. One of the questions, the most popular question here on Slido is about adult social care. And we hear a lot about the possibility, at least, that problems in adult social care are creating backlogs of people in hospital not being able to get out, which is itself kind of funneling all the way down the hospital system into not being able to get people out of A&E, not having the capacity to do elective surgery and so on. Is that, how big an issue is that in your mind?
Yeah, it's a massive issue. Again, it's different in different parts of the country. So in the place I work half the time, in Northumbria and North Tyneside, Northumberland, we have very few delays. So social care is still largely functioning quite well. We're working with colleagues to develop our own domiciliary care and stuff, but the councils are generally still managing pretty well. In other parts of the NHS, you can have a very large proportion of your beds taken up with people who should be in an alternative setting. And that absolutely, it's not good for the patient, the person, so they are more likely to come to harm. But it does then make a lot of other things very, very hard to do. One of the things that's hard to describe is how much work, there's a disproportionate amount of work involved in trying to get somebody discharged when they're delayed. So that can involve teams making dozens of phone calls every day, rather than when they should be looking after people who are sick. So it's hugely unproductive. That whole thing is hugely unproductive. But it's in most places, but it's worse in certain parts of the country. But it's definitely a big part of the problem. With social care, it feels a bit like the workforce thing. We're in a period where we're talking about it and acknowledging it. A lot of people still don't fully understand it, and we often mix up how it's funded versus how it's delivered. And that it's dangerous to mix those things up. So I think we need to just get our heads around, those different things. But one of the things that is a big step forward is there's a huge amount of money going into social care next year and in future years, and lots of money into the interaction between health and social care to create new capacity to allow people to flow better through. So it's acknowledged as an issue. It is definitely a big problem. So there's still over 10,000 patients in hospital who shouldn't be there. It's a massive proportion of our beds, but it's going to take time for that capacity to be created and used effectively with our local authority colleagues, and feel like we're kind of really focused on that together. So there's some signs of optimism in that, but it's complicated. None of the things that we do are particularly straightforward. I do worry that there is some data that suggests now that especially if you're old and frail and you're admitted to hospital, the chances of actually going back to where you came from are much reduced compared to where they were pre-COVID. We're much likely to try and discharge you into a social care setting, into a home, etc. And that's usually not good for people either. So I think we really need to get focused about this, not just on the numbers, not just on the impact on beds, but on vulnerable people who need looking after and their lives extending if it's possible.
I've heard it said, and I don't know whether there's data on this, that there is an issue around some hospitals being overly cautious about how they discharge people into the community. They're not willing to accept being looked after by relatives, for example, and that this could be debureaucratised a bit. Is that something you recognise? Yeah,
again, I think there's a combination of factors at play there. So I think, if we're honest, a lot of clinicians are nervous because of what happened in the first round of COVID. So in the big push to discharge, I know clinicians who carry the painful memory of discharging people who subsequently died in a care home of COVID. That's bound to change how you look at risk. It's always been the case that risk thresholds are different between clinical teams, and certainly between hospital and community services and the NHS and social care. Everyone has a different perspective of risk, and family attitudes have changed over the years as well. The extent to which people feel able to look after people in the home is very much different in England now compared to what it was 10, 15 years ago. The point is, I think that needs to be a proper joint conversation about what's right for the person, and we have to get out of this shoving it back and forwards as it's a health and social care problem. It's a people problem. We need to have a conversation about how to get that person into the right place for their needs. And I think there's a start with the money, start about discussions of acknowledging it's an issue, lots more discussions with led by ICBs about how those conversations happen, but it's a long road.
Victoria, you must see this in talking to staff and patients.
Well, I mean, the interesting thing is about some being too cautious and some being, I wouldn't use the word gung-ho, but, wanting to get them out as quickly as possible. And I've been in some areas of the country where it would appear that they have slightly reduced the frailty of the person on the books, and said to the care home, come on, you can take this person, and it has been the care home doesn't have the right level of staffing for that person whose dementia might be worse than has been made out, or that. And then there are some, yes, where you can see that it is being too cautious. But of course, what we know is that there isn't enough capacity in the social care setting. So you might want to get them back into their own homes, and that might be ideal. But for many, they have to go into a care home, and there aren't enough staff. So we filmed in a care home a couple of weeks ago where the whole top floor was closed, because they just could not take any more patients or any more they're not technically patients by that stage, but any more residents, and yet the hospital was bursting at the seams. So there was a disconnect, an obvious disconnect there. Actually, I was just reminded that a couple of years ago, filming in your trust, and where the social care, where it was working pretty well, but it had slightly slowed down because all the care workers who joined during COVID, because they'd lost jobs in other sectors, had disappeared to go and do panto.
I've not heard that one before.
No, I want to investigate that one. But yeah, I think Newcastle obviously has a lively pantomime.
Do you see in your role, Roberto, the importance of the role of social care?
I think getting discharge right is fundamental, because if the discharge isn't planned right, the GPs are often the first people that have to pick up the pieces, as it were, because the patient's often ending up going back into hospital. So I think getting that discharge is right, and that support, and that could be family, it could be professional support. It is really fundamental. I mean, in Tower Hamlets, we've got integrated teams in our hospitals trying to arrange these discharges to ensure that risk is managed across the system and not just in the emergency department effectively, which is where the seams are bursting, as you described earlier, Victoria. So we're trying to work out ways of how we manage that risk across the system and accept some risk, as you say, Jim.
I'll come to the room in a second, but I'm just going back to the top on the Slido now is about variation around the country. So I'll turn to Max and Jim on that. I mean, what do we know about variation around the country in waiting lists, in both scale, what drives them, and how well they've been managed?
So we tend to look at the national picture. I think Jim is much more on top of the kind of regional differences, so I can...
Okay.
Excellent.
So thanks for that.
Well passed.
It was absolutely the case. It's still the case that problems in terms of long waits and list growth are concentrated. They're always concentrated into a small number of organisations and a small number of geographies. So there's roughly 200 trusts. We've actively worked with probably about 20 on average at different points through the period. Most of the NHS is then able to just progress without too much support and scrutiny and oversight, etc. That was very concentrated in the Midlands and the North West initially. And I think when you stand back from that, some of that is pre-COVID performance. And I think your chart that showed what was happening with the list size pre-COVID is interesting, because actually if you just straight line that, it takes you over 5 million anyway. So there was a natural inherent deterioration of performance before COVID. So a lot of, in any crisis, your ability to recover is usually driven by the shape you're in at the beginning, as well as what happened during the thing. So that's absolutely an issue. And then extended periods of lockdowns were much more of a thing in the Northwest and the Midlands. Primary care was much more curtailed in those parts of the country as well. So you can absolutely see that playing out in terms of variation and impact. London, the southeast and the northeast looks like it can make a much quicker recovery electively than the northwest, southwest and the Midlands. So what we've been trying to do is level the load as much as we can. One of the big things we're really trying to do is to get off the ground on a virtual outpatients model. There's some good partners in the system now able to start doing that. So it is now technically possible, if you're waiting for an outpatient, to see a physician, probably something that's only going to require 1 or 2 interactions, not lots of complicated tests. You can actually have that anywhere in the world from your home. So we've got to be able to embrace that and make that possible to help accelerate recovery around parts of the country that are going to take longer naturally to recover than other parts. But on the variation point, generally, we've always got variation. We've got in financial performance, elective performance, urgent care, productivity. It's a function of humanity that you'll have variation. We're all very focused on trying to be as productive and match the best as much as we can. We'll never eliminate variation completely. There's always going to be some degree of variation there, but I think the GIRF team brings a lot of evidence and clinical sign into the process to do that, and we've been very conscious of it during our work as well.
And do you think the different trusts are good enough at learning from each other, learning from best practice, taking it on when it's evident?
So we would generally, the instinctive response is the NHS is not great at learning from each other. Honestly, the thing that really comes to mind then is that 2 or 3 weeks before COVID really hit, and the extent to which I remember before the first lockdown kicked in, talking to a clinical colleague in Leeds who had just seen images from Lombardy, and then quickly seeing messages in the critical care community about whether NIV worked or it didn't work, and literally things were being established in one part of the country on a Monday, and we in the North East we were about 2 weeks behind London. So the way the NHS in the North was learning from what was happening in London and then changing clinical systems in flight was unbelievable. Absolutely fantastic. The NHS totally at its best. And then we've sort of settled into a more of a normal rhythm, but through our programme we've seen a huge amount of sharing and activity, and people exposing good practice, learning from each other. It's just hard to do when you're busy doing what you need to do, and also organisations volunteer and help. So we've got a process now where people can volunteer to help others in other parts of the country. Before Christmas, I had a conversation with Mike Deegan, who runs the trust in Manchester. Had a problem in one specialty. We connected him to 2 chief execs in the North East who were immediately willing to help try and address that problem. And then in that, there's always a bit of learning. Oh, you do this, well, we do that. That's interesting. Let's try that out. That's absolutely happening all the time now. But there's nobody sitting around with loads of time able to stare at Google and find novel ways of treating people. Everyone's flat out. So we've got to find ways of just making that easier for people as much as we can.
I'll come to people in the room now. I mean, if you could say who you are, where you're from, and make sure you wait for the microphone. I'll start right at the front because that's the easiest, but I will come to others, don't worry.
Hello, James Illman from the Health Service Journal. A question for Jim. So we're running a story later today about something that there's been a lot of discussion about in the NHS management community at the moment. That's particularly NHS Trust and ICB finance teams. They're very concerned about new guidance that's come out on how elective recovery funding is being distributed, which is of course funding that's going to drive cutting of backlogs, and the finance directors saying that it's too complicated, and there's this particular concern around trusts having multiple targets with different ICBs and how they're going to get around that, and that it will stymie progress. I just wanted to get some of your thoughts on those concerns, and what's your message to the finance teams?
Yeah, thanks, James. So first of all, as has been said, and we all agree, the NHS needs to do more work next year and the couple of years after that. PBR is an established mechanism that enables that, and we've been in a block world, and there was agreement reached in the autumn. We needed to move into a PBR world to try and facilitate the NHS doing more work in organisations knowing that they're going to get paid if they see patients. So we're in a bit of a painful transition, first of all, on that, and it has absolutely exposed in the conversations some wrinkles that need ironing out. One of them is the multiple commissioner issue. As an ex-FD, so I was an FD in GP fund holding times, and then the 4 or 5 versions of whatever we had after that. I can't ever remember a time when I had a single contract, ever. No organisation's ever had a single contract. And I've always had to cope as an FD and a chief exec with having different contracts with different commissioners, and some might mean you need to do 5% more work, some might mean you need to do 3% more work, some 7%, just because of what's happened with demand and natural flows and fluctuations. So we absolutely now have to look to that again, having had the block arrangements that were much simplified, but there is an argument that the block arrangements have contributed to our loss in productivity. I think that's a real issue that we need to confront. I've heard it said, does that mean that trusts will stop treating patients in January or February when they've run out of money from that commissioner? And I honestly think that's absolute nonsense. The idea that an FD, A, would have that much control, and B, anyone would listen to him or her if they said to clinicians, don't see those patients because we're not going to get paid. Absolute nonsense. So it's a painful transition. We will absolutely, with Julian and other colleagues, have to iron some wrinkles out before we fully go live, and there's a live conversation going on about that. But we have to recognise that we need to do more work. We need to be more productive. We've got to get the transition out of the old world into the world that we need to be in this next period. And I think a lot of what you're hearing, James, is pain of the transition, the realisation that organisations actually have to see patients to get paid next year versus getting paid whether they did or didn't see them, etc. So it's a natural consequence of that. But people need to flag the issues as they have. That's an issue. There are a couple of other issues about how the unwind happens that we're working through as well. There's probably maybe 4, I think, real live issues that need to be ironed out properly.
Okay, there's a question here. The man 4 rows back.
Nick Bosanquet, retired professor, now a co-founder of a new consultancy aiming for health success. Can I suggest one way we can make the most of this investment in hubs and really deliver on lower waiting times, and that is to set up a virtual hub club by which they exchange information about costs, productivity, the optimum size of hubs, the performance levels of hubs, because there is a danger of too many applications going in for hubs. I think there's 7 in East London. And also of not getting the oomph that we should be getting out of the hub thing. There already are hubs, Wrightington, Oswestry, Nottingham, and the area which has the most hubs, which is South West London, also has the lowest waiting lists. Fewest people wait, I think none waiting more than a year, and that's because of Swellock in Epsom and the Croydon one, which started the local initiative. So a hub club, that would be, I think, a very good way of getting something out of this huge investment starting up.
I'm not sure if there's a question there. Shall we move on to the lady in the green jumper back there?
Well, there is a question, but I'd like to know whether he agrees.
All right. Well,
so I
do you
agree.
agree with hub
I
clubs?
agree, and I'll pick it up with Tim Briggs later on today when I see him. Good point, Nick.
Hi, I'm Eleanor Hayward from The Times. Just wanted to ask Jim how much you think strikes will throw a spanner in elective recovery plans. Do you think if they carry on for the next few months, you might have to sort of rethink the targets? Could it ruin the chances of meeting the plan as it is?
Yeah, thanks for that. Again, helpful question. So I'd agree with Victoria. We all just want this thing to be sorted out. Nobody likes it. It's unhelpful for everybody, especially the patients. So we need to try and get to a point where we can draw a line and everyone can move on. It's been hugely disruptive so far, but largely the NHS has managed to navigate that so far and make progress. So far, there's a lot of reschedule had to be done. There is an impact on every day of industrial action, but largely so far the NHS has managed to get it rescheduled quite quickly, and patients' pathway is not massively disruptive. That obviously gets harder over time, and the cumulative effect kicks in over time. And every kind of industrial action is actually quite different. So the nurses being on strike is different to the paramedics being on strike. And then the junior doctor thing is a completely different thing altogether as well. So we're not in a place where we're saying we're going to give up. We need to all absolutely try and minimise disruption as much as possible. And by the way, all the staff I've talked to who've been on strike, they don't want to be doing this anyway themselves, and they feel the pain of the disruption for patients as well. So we just have to hope it gets resolved quickly.
Victoria or Roberto, do you have any more to add on your perception of the impact of the strikes?
Well, I would agree with that. I mean, it's constantly we're asked to, and I'm sure Eleanor has as well, you're asked to find the patient who's fed up because their operation's been cancelled. But on the whole, there seems to be a lot of effort being put into making sure the days that follow that they can cope. There was pre-strike, every trust, I think, had to put together an action plan, and they had a sort of like a war room where they were moving things around to try and ensure that there was as little disruption. And so far, that seems to, as you say, have been fine. I mean, no matter what the rhetoric from some politicians, I saw on Monday rather, a nurse go off the picket line and back into the ward because the emergency department had suddenly become unsafe and too full. So there is a lot of flexibility too, I think, in the system.
Yeah, very similar, I think, to Victoria and Jim. I was at London Ambulance during one of the strikes, and again, I saw that frontline professionals going back into the ambulances to support when there were urgent calls, and everyone I speak to just wants it to be over.
Good, don't we all? Gentleman here.
Andy Camp from Health Policy Insight. The panel have talked about the importance of staff morale in particular. I wonder if you have any reflections on why the NHS staff survey data seems very rarely to be used to drive change in organisations. Also on the supply side of the backlog initiative, we know from the King's Fund's 2011 publication, Making Sense of the New Labour Health Reforms, that the vast majority of the reduction of the backlog in the 2000s decade was carried out by NHS staff working extra sessions in the evenings and weekends. I wonder what the panel feel the role of pensions, take tax and annual allowance is playing in disincentivising that kind of increased activity today.
Some big questions there. How do we get staff morale up? I'll come to Jim and Max, but Victoria, again, I'm going to come to you first. I mean,
Thanks.
Staff morale, and again, I mean, have you talked to these doctors who are allegedly leaving in droves because of their pensions?
Yes. In fact, I was filming in I've forgotten which part of the country I was on this one, but marvellous emergency department doctor, consultant, inspiring actually. And then she said, I'm going part-time next year. There is nothing for me to stay. I'm exhausted, I'm stressed out, and it will cost me money to do to work the way I'm working, so I'm going to go part-time in a hospital that could ill afford to lose her. So yes, it is having an impact. You can see, I mean, the British Medical Association keeps trying to talk about it, but it's so complex, it's actually very hard to describe to the public what the issue of the pensions is. I mean, we can barely understand our own, let alone NHS pensions.
So wouldn't this be totally straightforward to solve just by saying if you get to the cap, then you just opt out of the pension? I mean, isn't that all you need to do?
They've already done so for judges. They've already resolved this for High Court judges. This is entirely making a change for this rather crucial group.
They made a tweak at the beginning of the year, didn't they, which doesn't seem to have had much impact.
Yeah. So can I answer the questions as well? So on your point, Andy, about staff experience, it is the staff experience and patient experience in My Trust Life are the two main things. So everything else is driven from that. We relentlessly measure it. We ran a survey over the peak horrible period, December, January, and then had to confront that. Staff were telling us it wasn't as good as they wanted it to be, and that's hard as a management team to confront. You have to confront it and then do something about it. That's our job as leaders, and I think, as Victoria said, that's now much more prevalent around the NHS than it used to be. I think the local surveys are much more responsive than an annual staff survey, because by the time we get the staff survey results, are actually 6 months or so past the point at which the survey points, so they're not as useful as you'd want them to be. So I would urge everybody to really embrace that locally and understand what's in people's minds and what patients think, match the things up, and then drive your decision making through through that. On the pension issue, we all, again, it's like the industrial action. We all want it to have been solved, but it's a very complicated matter. On your point, Paul, a lot of organisations have been doing the contribution recycling thing, which basically is, if you think you're at the cap, the employer pays you your pension contributions as cash, taxable income. That's been in play in the NHS since about 2010. It's not been widely taken up, but it is accelerating in its take-up. The issue is more about people actually understanding it well enough to know when to come out. And that's very complicated. It's actually very hard even to get advice on it because the NHS scheme is so complicated.
But
So
that must be fixable. I mean, it must be possible to hire a few competent people to provide the advice.
You would think so. But we haven't managed to do it yet. I don't fully understand the judges scheme, Andy, but what I've been told is it did actually cost money in that department, so it's not. It wasn't neutral. So,
whereas what you're describing, people have been doing since 2010, is neutral,
totally
and
neutral.
Everyone's a winner. I don't understand why. Anyway, it's baffling. Max, do you have anything to say on the pension side?
Yes, we've actually thought a lot about this pension stuff. I guess the worst point was solved in 2019-20, where the tapered annual allowance was causing a lot of problems. The threshold for that has been risen a lot. I think the annual allowance still could be causing problems. I think a big thing is it's really complex for doctors. We, as researchers, try and think about these pension things, and it's really hard for us, and I think for anyone on the ground it's going to be hard. I mean, our colleagues just a few days ago published a lot of kind of proposals on improving pension taxation more broadly that would hopefully help in some of these, including, I think, removing the taper entirely from the annual allowance.
And making the annual allowance more generous.
Yeah.
More questions. Lady right at the back in pink. I'll come that way now. Sorry, I'm making you jog round, Carol.
Hi, Sue Chan from The Telegraph. Just looking at this from a shrinking workforce perspective, what has been the impact of people waiting 18 months, 2 years for treatment? I know the statistics have told one story, but since we've got a GP on the panel, are people on the front line? Are people working fewer hours? Are they giving up their jobs altogether? And just a clarification for James, if I may, do you think the pension tax system as it stands today is an issue for the people that work for NHS England?
Okay. So with shrinking workforce, you're referring to the national workforce, not the NHS workforce.
Correct,
Do you see this, Roberto? Do you get a sense that your patients are leaving work or working less because they're not able to get the health treatment they need?
In part, some patients choose not to. I think it causes huge disruption to patients' lives in terms of being able to do day-to-day activities, and that's what I hear in my consulting room. I also hear a lot of fear of where they are in this long waiting list, and often not knowing when their appointment's likely to be, and could it fall on a holiday or a wedding or something like that. But fundamentally, I'm seeing a lot of patients come back, despite me seeing them, assessing them, treating them, diagnosing them, and referring them on. The next step is they need hospital input, but because they can't access that, they often come back to me, which is perfectly fine for me to consult them again, but it prevents me from seeing someone with a new problem, which then compounds the I can't get a GP appointment.
Victoria, I mean, is this something that you've been able to talk to anyone about? I mean, you've chased these people who are fed up with the NHS and can't find them. Have you found people who are not working because they can't get treatment?
Not personally, but I mean, you see a lot of it anecdotally, don't you? But what I've heard most is about the patients returning into the GP system who wouldn't normally be there, so their condition is deteriorating, and so the GP is having to pick up where the hospital would normally have taken it, therefore making people annoyed because they can't get a GP appointment.
Max, I think we're quite keen to look at this, aren't we, by looking at how this varies around the country, but am I right to say we haven't managed to do that yet?
Yes, it's definitely something we're looking at. Colleagues have looked at the rise in health-related inactivity, and my reading of their work is it's mainly people who are already inactive. It's not necessarily directly pulling people out of the labour force, but there's clearly issues here, and it's something we'd really like to look at, yeah.
I mean, it's quite extraordinary. You look at any of the statistics, and the population is so much more unhealthy than it was 3 or 4 years ago. It's quite staggering. There's a very specific question about pensions for you there, Jim.
Yeah, so in my trust experience, the pension recycle scheme virtually eliminated the concerns about the pension tax and changes to it, and hasn't prevented us from anybody doing any extra work, etc. There are other trusts where it's still said to be a big problem, and I spoke to a group of clinicians in about October, November, who were very angry about it, and what they were a bunch of clinicians who largely were my sort of age, in the 50s, had come into the NHS with the understanding they were going to get a particular pension as part of the package. Nothing was going to make them happy other than going back to what they started the NHS with, and you can completely understand that. They've made life decisions on that, etc. But I really can't see a scenario where we'll go back. So I think it is about how we embrace what the alternatives are to allow people to continue to work, have certainty of payment, but also that they're not going to get a very big bill. And on the bill thing, earlier doors, I remember speaking to clinicians who were getting bills of 30, 40, 50,000 pound, having to think about whether they sold the house to be able to pay their tax. And that does make people hesitant then about doing something, then tripping over a barrier and then getting a big tax bill. It's a natural thing to feel very anxious about. But the recycle thing does largely get rid of that issue, I think. It's absolutely not as good as what they came into the service expecting, but I think those days are gone.
Okay, gentleman with the beard just along here.
Hi there, I'm Ollie Parsons from Versus Arthritis. I just wanted to back up the lady's point and say yesterday we were in 10 Downing Street to hand in a petition, 28,000 people signing to deal with the backlog, but I actually took one of our arthritis campaigners to meet their MP. Brenda waited 3 years for 2 operations from just before COVID, and she's just had her second operation. But she was working a really well-paid job in the city for a law firm. She's had to give that up and she can't work. And she really wanted to go back to work. She would have been able to, she thinks, and the doctors think, if she had the operation earlier on. But Brenda's just one example of people that are having to wait much too long, and it's impacting on their employment prospects. So now she's had to sell her house as well.
Okay, thank you. Gentleman right at the very back. I'm being very inclusive here.
Thank you. Aaron Harrell, I'm a civil servant. Many healthcare systems around the world, public healthcare systems, accrued a backlog post-pandemic, having deferred treatment and indeed deterred patients. How does the NHS compare, and its approach compare to its peers?
Great question. I don't know if our panellists can answer that. Victoria, you've already admitted to knowing something about at least one other health system. So have you got any sense of this?
Well, I have been looking, mostly because I fancied going somewhere else to report on their struggles than going to, as my sister says, I always go somewhere beginning with B. And I have been looking at Canada, France and Germany, very different, of course, different health systems, but struggling, slowing down in productivity. New Zealand, I would say, absolutely on a par with here, and a lot of it is about workforce issues, having lost the workforce and not knowing where they've gone, having people not being able to, so they, like here, used to get a lot of nurses, for instance, from the Philippines, so that of course stopped when they closed the borders. All those similar issues with the same impact. And New Zealand's probably, maybe Canada, probably the most comparable of the systems, and very much the same problems they're seeing.
Yeah, there was quite a comprehensive article in The Economist a couple of weeks ago which went through this in some detail. Has any of the other panel members got anything to say about what's going on in the rest of the world?
I think one thing on this is I think sometimes it's unfortunate for the NHS, by being a national system, we have great national statistics about what's going on. Lots of other countries, you can't do that, so it's actually really hard to compare, and that's almost a problem for being such a good national system in that sense. Yeah, absolutely.
It's very rare you hear someone from the IFS saying that we've got good statistics.
Well, they could be better.
An important rider.
Yeah.
Nice. Gentleman up there.
Thanks very much. Jonathan Holmes from NHS Providers. My question is broadly on the topic of variation. One of the causal factors we saw in sort of how quickly waiting lists grew was with relative deprivation. When the elective recovery plan came out about a year ago, that was a consideration in how waiting lists should be managed and tackled. In that time, improvements in population health and reduction in inequalities has become a core function of ICBs. I was just wondering, sort of looking back at the last year of progress, how inequalities have been factored into that, and how going forward inequalities reduction might be considered, and how trusts can support that intention.
Well, another huge question, and we turn to Jim for the big ones.
So it had huge prominence at the beginning, and we were very anxious to just sort of understand it. Took a lot of advice from Bola and other colleagues in terms of the overall approach. And I think it's a bit like the workforce thing, the service being very sensitive to the impact on inequalities of what's happened, but also trying to make sure we recover in an even way, in a fair way, as much as possible. I think it became quite apparent really quickly that that's actually very different in different parts of the country. So you have to really understand what that means for you. And we see when we're interacting with organisations that pretty much everybody's got a local approach, that they're taking the national approach, but can tell a story about certain groups of society in their place that they're worried about, using instruments in terms of triage mechanisms and clinical prioritisation to make sure that it's as fair as possible. But it's not something that's just uniform everywhere. It's very different in East London to Blythe in Northumberland, for example. So I think we have to keep an eye on it and make sure we don't see signs in the data of things deteriorating. But it does feel like it's quite well embedded in the NHS psyche now as something to worry about and have a very tailored local approach. The thing I am most worried about as a chief exec, and we've touched on it a few times, is on that missing patients thing. We're constantly trying to look at the data to see whether we are seeing the sort of numbers of people who've got heart disease or diabetes or mental health problems or whatever, and increasingly having to think about patient finding and searching for people and trying to get them, at least have a contact with them so you can get them into the system. That's a very hard thing to do when you've got more work than you can cope with. But again, you can see that happening around the NHS. So I think we need to keep an eye on it and make sure it doesn't just drift off as people kind of feel like they're getting back to normal, because it's a very big issue. And we mustn't forget the Marmot update just before lockdown, first lockdown, of what that found, and we've gone backwards in a lot of things over the previous period. So I think it's there. I think it's embedded. It's just very different around the country.
Well, we're almost at the end. Is there any last questions? Then I'll come to the panel for final wrap up. I'm going to, so Adrian and then Lady in Red and the two gentlemen at the bottom. If you could do very quick questions, then I'll get the panel to wind up.
Hi Jim, Adrian Masters, X number 10. Can you just say a little bit more about outpatients?
Mm-hmm.
Because as you said in your talk, it's where the big volumes are in elective care. And I know you personally have got have had for a while some excellent ideas about how we can improve outpatients and reform it. Yeah, and we don't have the problems with beds, and we don't have the problems of having the extra capacity for operating theatres. Yet we've got extra staff. We have 9% extra staff, but we haven't yet had 9% extra outpatients activity. It's where the big opportunity is, I would say.
Yeah.
So do you want to comment why? Is there a problem, or is that where we should expect to see the big improvements start to come through on outpatients?
Okay, great question. Can we collect the other questions? Then I'll come to all of the members. So there's a lady in red here.
Hi, I'm Millie Tozer from Independent Healthcare Providers Network. I just had a quick question on, Jim, you talked about the importance of patient choice and patients being able to take control of their own care. And we did quite a lot of work with the Patients Association on this last year, but found that one of the biggest issues is kind of the lack of public awareness on the fact that they have the right to choose a provider. And I was just wondering if you had any kind of opinion on how we could improve this.
Great. Now, 2 very quick questions, I hope, down here. Here and here.
Thank you very much. Paul Hudson, I've retired. I spent most of my life in academia, but I've also worked in banking, brewing, shipping and financial journalism. One of the things that has occurred to me is that I'm struck by the number of CEOs in hospitals who don't have any medical background. We seem to have a lot of amateurs, rather like the British ministerial system. Having worked for almost 6 years in Germany, I was struck by the contrast. Usually the ministers have some background of the field in which they're working.
Thank you. So I think yes. I think they might be slightly offended by calling them amateurs. This is a big leadership role. Finally, last question.
Yes, Sam Blanchard from The Sun. I just, Jim and Roberto, want you to know what you think is the biggest threat to the Grand Recovery Plan. Is it internal or external? And
Okay.
you go with that.
Great questions. Let's start with Victoria, Roberto, Max, and I will give Jim the last word. What about outpatient? Shouldn't we be focusing on that? Is patient choice making any difference? CEOs without a medical background, and most interestingly, what's the biggest what's the biggest worry here? I'm definitely going to insist that Jim answers that one. Victoria.
Just very quickly on patient choice, I think that is an interesting point, because I think patients don't know. Some of the polling, I think, in the past has shown that patients don't want to take that choice, that they don't want to move too far away from where they can get their nearest medical treatments. I mean, talking about wanting to go abroad, I did once go with a patient to France, to a hospital there, where he had taken up his choice and there had been a deal done between the two governments. The other thing that hasn't come up is greater use of the independent treatment sector centres, as we saw in the first days of the Labour government, which really had an impact on the waiting lists, and why we're not hearing as much about that now.
It'd be interesting to get Jim's reflection on that. Roberto?
I think patient choice is a really fascinating topic, and it's a patient's legal right to choose their provider at point of referral. I suppose, what would one base a choice on? Is it a waiting time? Is it a star rating? Is it a CQC rating? What would one base a choice on? And I think we've got to improve the data that we give to patients to be able to enable that choice. Otherwise, it becomes quite tokenistic in choosing one provider over another. I think a really interesting point about CEOs without a medical background, I think it just highlights the importance of clinical leadership and having doctors and other healthcare professionals, nurses, and so on, to support and help assist and lead projects, and that seems fundamental to me. I suppose biggest risk, I think, is being able to clear the backlog, to be able to help with the general practice backlog that I described earlier, so being able to have the system flow through each other simultaneously.
Max?
On outpatients, completely agree. We found it very surprising. Again, you have more staff, you have about the same number of beds. That might explain why we're struggling with elective, but we also are doing fewer outpatients as well as inpatients. I mean, I guess it's coming back to this being a complex system. Might well be, if clinicians are spending time dealing with inpatients, they don't have as much time for outpatients. So I guess that's another sign of it all intermingling. In terms of CEOs, non-medics, I guess as an economist, we love comparative advantage, and there's a difference between the skills that maybe take to run a huge organisation and the skills that take to treat patients. And of course, clinical input's important, but so is management skills, which aren't always the same.
Yeah, it's important to be clear, all of the economists at the IFS are much better economists than I am.
Okay, shall I rattle through? So Adrian knows I feel really strongly about outpatients. It is where all the volume is. It's where a lot of clinical time is tied up. There is a lot of wasted patient experience in that. And we really, my initial view was we need to invert the model. So the model currently is you see a clinician, you reach a conclusion, start a treatment, you get booked in sometimes for the rest of your life at regular intervals, whether you need to or not. And we need to invert that model and say, start a treatment. If clinically you need a follow-up, that's fine. Otherwise, you tell us if you want to have an interaction. You have control of it as a patient. And that's not fully taken off yet, largely because of clinical concerns about risk in some specialties, which is totally understandable. The worry about losing patients somewhere in the transition. I think headspace, people just not having the headspace, because to do it you've got to redo things like clinic templates and renegotiate job plans and huge amount of work. So there are signs around the country of people starting to do it, but it's a long, hard journey. But I still think you're absolutely right. It's still the big thing for us to really go at. Choice is absolutely, we're having to rebuild mechanics that we've had before about good data, making sure it's a real choice. People really feeling like they've had a good conversation about what their options are. That's difficult with primary care being as stretched as it is, because we'll rely on primary care colleagues to have a trusted conversation with patients. But we are moving more towards that space, and I think we'll continue to try with that. We should remember as well, when we had choice in the 2000s, a lot of people still didn't know they had choice. But we do know that a good conversation at the beginning of the pathway can enable choice. When you're trying to do it with somebody who's waited 18 months, they're much less keen to move. And clinical teams are much less keen to move. On the leadership point, as a gifted amateur, I'm an accountant, you just need the right team around you. And all NHS organisations have very strong clinical leadership. So I don't think it's about one profession having dominance over the other. You just need the right people to do what you need to do. Sometimes that's medics, sometimes it's accountants, sometimes it's HR people. I don't think it really matters. And then the threat, I'll not talk about technical threat. I think the real threat is that we'll lose sight of people in all of this, that the waiting list is made up of a lot of people who have needs, and our staff are people who have needs. And we can very easily just get totally distracted by the numbers and the metrics. The reason the NHS is so much loved by the population is because it's an emotional thing, and we have to cherish that, and that's what will get us through the next phase.
Well, look, thank you so much. Thank you to everyone in the audience, both online and in the room. That was one of the most fascinating mornings I've spent in a very long time. Of course, all of the IFS work is up on our website, and please do look at that and keep an eye out for the fantastic work that Max and Ben and George and Isabel, who do the health work at the IFS, are putting out over the next few months. Thank you so much to the panel especially.